management for MIS in here. This is a 50 years old businessman. He's the CEO of his own company. He had severe left arm pain over only 1 week, and I saw him in a week time. And, briefly, his examination was he was having neck pain, and he has some limitation, especially by flexion and rotating to the left side. His VAS was 5 for the neck, but he has severe arm pain. He's holding his arm to his chest all the time, and he's walking around. He's sleeping in a chair for the last week. An examination, although there is subtle weakness at C6 distribution, there was no myelopathy sign, and he's on maximum opioids and non-steroidals. And he tried 1 session of physiotherapy. He got worse, so he's here now for the management. Now, our option in general practice, many surgeons will go for SDF, or if he's going for surgery, or arthroplasty, or they will go for MIS. Now, if I put a poll in here for the faculty, I'm sure the majority will find this case very attractive and straightforward for MIS. And this can be either full endoscopic, anterior discectomy, or foraminotomy, or posterior foraminotomy or discectomy, or using the tubular retractors either anteriorly for discectomy and fusion, or posteriorly for only foraminotomy with retrieval of the fragments. Now, my talk briefly, I'm going to talk about the current evidence-based practice for endoscopy for tubular-assisted discectomy, and then we want to compare these MIS with the current traditional treatment like HDF and arthroplasty. And I'm happy to share this work with, guided by Dr. Alves, and we did our meta-analysis for the outcome of anterior and posterior endoscopic procedures. We want to provide quantitative summary to estimate the success rate, complications, and the type of approach anterior versus posterior. We collected our data from English literature through a 3-engine search for this procedure. And we started from 2003. This is where the start of the MIS overall happened until September 2020. The data collected from 31 studies, we looked at the demographics, perioperative variables, clinical outcome, and radiological also outcome or variables in these studies. Most of these cases, the mean age were about 48, and the follow-up was almost 2 years. The symptoms were there for 6 months in these studies. The operative techniques for endoscopy was 2/3 was posterior and 1/3 was anterior. And then one study included both. All study had foraminotomy and discectomy, and they removed the fragments. There was 2 studies for described the anterior transcorporeal discectomy, which will be explained in details by our faculty. And in these cases done under general anesthesia, however, 4 studies did a local with conscious sedation for anterior, and 1 study for posterior used the local anesthesia and conscious sedation. The perioperative parameter was really good. The estimated blood loss was minimal. It was a short operative time and hospital stay. And the post-operative analgesia was in 1 study in details showed less than 10 days cessation of the analgesic after surgery. Radiation exposure was not mentioned in this study, and the consistency of the removed disc materials was only mentioned in a few studies as a soft and 1 study as a hard disc. The pain control was really good, and the majority had significant improvement in neck VAS. It was similar between anterior and posterior endoscopy procedures. Right arm pain also was significantly improved and slightly better for anterior endoscopic procedures, and NDI also was better with the anterior, but overall it was really a very good result. More than 90% as a successful outcome was obtained from the studies of endoscopy, slightly lower in the anterior from our analysis, and excellent, again, 70% or 72 of excellent outcome, slightly less in the anterior approach. The poor outcome was 3.4%. Again, this was reported slightly more in the anterior endoscopy approach, but overall complication was 72% and slightly higher in the anterior approach. I will not talk about the details of the complication. Will be addressed hopefully by the faculty. The revision rate was almost similar in endoscopy group, whether you want to go anterior or posterior, is about 4.2%. So our analysis showed a overall very good outcome. We looked at the radiological outcome, what happens to the disc space, and only 10 studies looked at the radiological outcome. They looked at the segmental alignment and they looked at disc height. And in 4 studies, they mentioned there is a reduction of the disc height, whether this should be studied in the future for if there is any post-discectomy kyphosis will happen or not. In one study that reported that disc height is improved, actually that study where they did fusion with the discectomy. We briefly conclude from reviewing the endoscopy for cervical for anatomic discectomy. This is our first study which compare anterior and posterior. There is a higher success rate and lower complication with posterior approach more than anterior approach, but overall the success rate is high. Both approaches show significant improvement in all parameters. However, the disc height reduction should be studied in the future, and we need a bit longer follow-up for this one. The second part about the tubular retractor use in MIS, there's a tremendous literature evolving over the last 10 years, and we looked at the similar systematic review of 17 eligible search. We found the 3 studies had used the tubular retractor for anterior technique, but the majority used it for posterior approach. The demographic was almost the same as most of the patients were young. The majority were male, and they follow up to 2 years. And there is the majority, the indication was mainly for radiculopathy, and some of them used myelopathy. And there are some studies did not specify the indication. The incision and the estimated blood loss was minimal, and it has a short operative time and length of stay. The reported outcome was really very good in the neck VAS, arm VAS, NDI, and all the outcomes. And those patients who had myelopathy and had surgery through tubes showed significant improvement in their myelopathy. One study reported the patient satisfaction index, which was really very good by the patient. The anterior tubular cervical anatomy or discectomy is not very common, and it's been reported in 3 studies. Vergara from Germany reported their 6 patients with good outcome, and this is a day surgery and safe outcome. Romero from Mexico, and I think we have our guest, Professor Soriano, in the group. They used the retractor for anterior ACDF and arthroplasty, and their outcome was very good. The dysphagia rate is about 9%, which disappeared after 1 month, and they had a very good outcome. Maduri from Switzerland also, and their group had a good experience with the anterior use of tubular retractors with a very good outcome as an alternative to ACDF. Kim reported his studies and they found the outcome is similar for tubular versus open. Pain is much less with the tubular surgery, and the hospital stay was much less. He also compared the endoscopic versus tubular technique in his study and found there's no really significant difference. So using the tubular retractors in MIS is very good and safe and effective, and it can be a really good alternative to open surgery. There's increasing use of the tubular retractors anterior and posteriorly overall, and there's more indication like myelopathy, which could not be done by endoscopy. Now it can be done by MIS. However, we need still more study of long-term and level 1 evidence to describe it. Now, if you compare the MIS for ACDF, I'm just going to go very briefly here. This is one of the earliest reports from written and in prospective studies which compared ACDF to the PCF, and they found there is no significance different, and the outcome is the same. Another comparative study of ACDF with the PCF in a systematic review showed of 10 studies showed there is no difference in the complication rate, the clinical outcome, and the reoperation rate at 2 years. Another studies, Dr. Wang, they looked at the revision for after PCF, and they found that overall there's 5% revision rate of PCF, which is almost the same as the ACDF. The reoperation rate after discectomy and after PCF was reviewed in this good studies, and they found the reoperation rate is almost the same of ACDF versus PCF, and there is really there's no difference statistically in their incidence. This is one of the last study I will talk about. It's by Gutman. This is an interesting meta-analysis for 4 RCTs. Was basically analyzed the secondary surgical procedure and adverse events. They found all techniques, ACDF, CDA, and MIS, mainly PCF, are effective in treating radiculopathy. Minimal invasive PCF has the lowest rate of adverse events. Arthroplasty has a lower rate of secondary procedures, but overall there was insufficient evidence to conclude which technique is the most effective and which one is provide the longest lasting symptom relief. So overall, the current evidence in the literature for cervical MAS is show there is an effective an alternative to open procedure with very good outcome. The complications outcome and the revision rate is almost identical to ACDF. It's an emotion preserving procedures which does not cause adjacent segment disease, and it has less expense. There's no implant used, but it requires a really good learning curve and training to obtain such a good result. Thank you very much.
Saleh, thank you so much for your very comprehensive review. Carmen, you want to?
Yes, please. I'm very interested. This was a very interesting presentation. Thank you. Thanks a lot. And I have a few questions, and I hope you can enlighten me. Well, the first thing is when you talk about a anterior decompression, just the via MIS. Do you mean that you only take a part of the disc and leave the majority of the disc in?
In my practice, I haven't tried the tubular anteriorly, but I've reviewed the 3 studies. Dr. Suriani can explain more about this question. But from my reading, most of them, they will do the small incision to insert the tubes, and they will do a discectomy like we do in microscopically. And after that, they will put a graft or even arthroplasty implants. So what's been done is the same as the open microsurgery.
Yeah, I would think so. But however, then I do not quite understand the conclusion that there is no implant needed and that ACD is not occurring. Although I do not think that an implant is a problem or that ACD is a severe problem. But I was just wondering about that conclusion. But maybe you can explain?
No implants in cases where you want to do foraminotomy, either endoscopic or MIS. It's an advantage because in these cases there's no implant. But if you're going from the front, and these cases, most of them, they have some sort of myelopathy, and in these cases where you want to do MIS and remove the whole disc and do good decompression, in most of those cases, they will require implants. So my conclusion was basically on patients with only a unilateral radiculopathy who are going for MIS, either endoscopy or through tubular, either anterior or posteriorly, without having to take out the disc. So this is advantage of not using the implant. But I agree with you. If you are doing a total discectomy in those cases, and this is done only for myelopathy cases, then I agree. I don't think the implant issue will be a problem.
Okay, and then one more question, please. That is, when you went over the literature about comparing anterior and posterior decompressions, I really like that research question, but I usually am in doubt whether the population is different. And maybe you can enlighten me because you went over all the literature. In my opinion, when I choose to go from anterior, then the bulging disc is somewhat more medially placed. And when I decide to go from posterior, the herniated disc is placed somewhat more lateral. And therefore, I think that the patients that are operated from posterior are happy because you operate them well. And when you go from anterior, they are happy. However, I am wondering when there is a herniated disc that is located somewhat more to the medial part, I think that posterior decompression there, well, I'm in doubt whether that would help. But did you encounter something like that in the literature on that?
Yeah, I agree with you. There's a significant heterogeneity in the literature from anterior or posterior, but from my reading, it was very hard to extract such indication why the anterior was choosing more than the posterior. But I agree with you. I think a fragment which is more medial, a calcified disc is which can be done from anterior endoscopic might be a good option to go for it. But in some cases, like the one I showed an example, there was a split in anterior and posterior indication. But this question, I mean, we need more and more information from the literature to know which one we have to select, anterior versus posterior. I agree with you.
Okay, well, that gives us...
Yeah, I think some of this meta-analysis really compares apples and oranges. And we have the occasion to discuss this. So thank you, Saleh, for your very nice presentation. And next, we need to move, and we have a pioneer and a legend of spine endoscopy, Professor Ganshoy, has an unrivaled expertise in endoscopic anterior discectomy, which is his topic today. Professor Choi is president of Pohang Guri Spine Hospital, professor at Anyang University Medical Center, executive director of the World Congress of Minimally Invasive Spine Surgery and Techniques, and former president of Korea Minimally Invasive Spinal Surgery Society. Dr. Ganshoy, it's a really great honor to have you here at this webinar. Please.
Thank you, everyone. I'm Ganshoy from Korea. Today, I'm going to present about anterior endoscopic discectomy. Previous, the Dr. Balsa, he reviewed all the technique for the anterior or posteriorly, the approach for the radiculopathy patient. Today, I am going to present about percutaneous endoscopic cervical discectomy. This is animation. We retract the anterior esophagus and the trachea and protect the carotid artery, and anteriorly. Mostly we approach it contralaterally for the disc herniation. So this is animation. Most of disc herniation is outside of annulus, so mostly we need the laser system for make a hole for removal of disc herniation. But this indication is very narrow. It should be soft disc herniation and not migrated, and mostly C4, 5, 5, 6, 6, 7. 17 or over above the 3, 4 is difficult. This is a simple video. Anteriorly, I always do this procedure under local anesthesia because I need the patient response feedback. By using side firing laser, and then finally we can remove endoscopically. This is a pre-op and post-op MRI, pre-op and post-operative MRI. This is another video. It's by Curtis of Juno Lee. Sometimes you can see the annular tear side, and by using side firing laser, open the annulus. The herniation is outside of annulus. Finally, we can remove the ruptured herniation. This is a pre-op and post-op MRI. Pre-op, post-op, pre-op, post-op. This is a 24 years male patient is shooting pain down to the leg and neck extension. Tingling around the neck region, tingling from left shoulder to left little finger since 3 months. This is MRI lateral and sagittal and axial view. Before the preoperative planning, we always check the CT scan as well, because we want to know is this disc herniation, whether calcification or not. If it is a calcified disc, it's not a good indicator. Endoscopically, C5, 6 on the local. So with the 2 finger, this is very important. With the 2 finger, the nail side, we push the trachea, and the inner side of a finger, we have to feel the carotid precision and retract the laterally, and small inject the indiocarmine and guide wire and small incision and then insert of cannula. This step is very scare time. We position the cannula almost the posterior until posterior body line. On the endoscopically, I use the side fire laser, open the annulus, And this is the final step. My forceps it should be beyond the posterior vertebral body line. Finally, we can see the dural and parallel pulsation. It's a posterior postoperative MRI. The postoperative immediately the symptom is improved. This is a postoperative MRI. He's from Saudi Arabia. Another patient, 35 female, actually she was the nurse. It's a pain in the right arm for 2 months. It's X-ray, a little bit disc space narrowing and slightly kyphosis. It's MRI, C5-6 right side ruptured herniation. On the CT scan, she has a little bit opular, but mostly the herniation is the soft disc herniation. So I decided cervical endoscopically treatment. Operating view, we use the bandage to retract the shoulder. We want to see the lateral view clearly. This is the animation. Before I already mentioned it with the 2 finger and then between 2 finger with keep my finger and injection, insert of needle and guide wire and obturator, and finally position the cannula. The cannula is almost the same level of body posterior line. This is an endoscopic view. I'm sorry, it's not work for the video. This is the final view of endoscope. My forceps is almost about posterior line. It looks very dangerous, but I did on the local anesthesia, and I always keep the interacting with the patient. Are you okay? Can you show your movement of leg and arm, anything? This is the post-operative MRI immediately. So this is my paper. It's a new progression towards a safe anterior percutaneous endoscopic discectomy. Previously, we used the hammer, but now I invented some of thread. So before we needed to a little bit hammering, but now we can use for the advance of cannula, we can just twist. So there are a lot of advantages of endoscope. No injury to normal disc, no arsonitis, no esophageal recurrent radial lobe injury, no need of stabilization, outpatient-based, rapid return, minimal scar. But it is a really quite surgeon-dependent procedure. It is very much demanding of procedure. disadvantage is very narrow indication, steep learning curve, and we need laser, like expensive equipment, and some of our radiation exposure. Thank you for your attention.
Thank you, Dr. Choi. Awesome presentation. I just wonder if you use some sort of navigation just to go right to the disc prolapse. Would you think it would be helpful to do some sort of navigate your scopes other than the X-ray?
We always use the CM guide. So actually, I don't need a navigation system, but in the future, maybe it could be available and perhaps for reduction of radiation exposure. But this radiation exposure is not really big. So actually, I don't use the navigation.
Okay. I have here a question from one of the participants, Dr. Ghassan Hassan from Iraq. He's asking a question. If you use a nasogastric tube to help you to identify esophagus, does it help or you don't need it at all?
What excuse me?
Nasogastric tube.
I do always on the local anesthesia. So I can feel the trachea, I can feel I cannot feel the esophagus because esophagus is always how to say, covering by same fascia. So if you feel the trachea and push away, and you have to feel the carotid pulsation is your side, and between, I always, my fingertip is very important. Fingertip should touch the vertebral body, and make a small space between two fingers. Still keep your fingertip is body, and insert a needle. And another procedure is just to follow with the conical, the tube, conical obturator. It means they split the another dangerous structure. So we don't use
your scope is not completely round; it's flat, right? In order to insert it in the disc.
Yes. Scope is flat.
Flat. Okay, Antonio, nice to have you here. So what's the difference between your technique with the tube and this one? What's the advantage? How much disc do you take with your procedure? Do you need
absolutely different, because in my technique we are making essentially a microdissection. We are in any moment afraid. We are not possibilities to damage any vascular structure, esophagus or whatever in the field. One of my concern about the technique of Gun Choi is that a few years ago, Jim Carragher described how the punction of the disc with a even small needle accelerates a lot this degeneration. So my question for Gun Choi is, what about the long-term follow-up with the patients with this technique? Because essentially the endoscope is bigger than any needle. So what happens with in the future, in the near future? Hi, Gun. Nice to hear you again. Hello.
Hello, Soriano.
Hello.
The patient is a herniated rupture disc herniation. It's already degenerative disc mostly. So even we don't do any the insert of needle or cannula, naturally the disc space will be decreased. It's not normal disc. It's already degenerated. So I try to keep almost all the anterior support. It means the ALL and most of the annulus and facet joint. Just I focus on the lumbar disc herniation. So with the long-term follow-up, 2 years, definitely the disc space is decreased. Statistically significant, but clinically mostly it's okay. Just a little bit, 10%, 15% as the decreased disc herniation. So I already always mention about the decrease the disc height. It may be need fusion surgery or artificial disc herniation to the patient. But mostly it's okay. Maybe I don't have a real data, but maybe 10% patient in a future follow-up, during the follow-up, they need ACDF or artificial disc herniation.
Thank you, Gun.
Any more questions? If not, we can follow the track with a gentleman's crossfire on posterior-based treatments for radiculopathy and myelopathy, such as tubular guided or endoscopic laminoforaminotomy for decompression of neural elements. For this, I invited Professor José Antonio Soriano. It's a long-time friend from Mexico City, president of Mexican Neurosurgical Society and FLANC, and also Professor Jing-Sung Kim from Seoul. He works at the Spine Center, Department of Neurosurgery, St. Mary's Hospital, and College of Medicine in the Catholic University of Korea in Seoul. He also serves as deputy editor for Global Spine Journal and Neurospine, and is a recognized world expert in cervical endoscopy.
Thank you. Thank you so much, Alves. Thank you, everybody. I hope everybody is well in this pandemic. I'm going to talk about minimal invasive cervical laminoforaminotomy, specifically tubular approaches. I don't have any conflict of interest. I would like to mention some universal premises about the spine surgery. The first one is there are many ways to peel an apple. So in the surgery, if open or pure endoscopy or tubular microsurgical, at the end, the important is the outcome of the patients. And it's very, very important. Of course, the art is influenced by the training a lot. And I would like to remember that I am neurosurgeon. So my training include the use of microscope always. So my training is with a microscope. That's the reason probably why I'm using microsurgical techniques. Tubular techniques are transitional techniques among the pure endoscopy using working channels lesser than 10 millimeters and mini open. So the tubular usually is through the 10 to 25 millimeters of working channel. So the learning curve is very important to be able to work through a small tubes, as you can see, with the usual instrument as in open surgery. All the usual instruments could be used. Midas, carries, some punch, etc., etc. No difference. So the next premise is that the spine surgery has to follow, and it's very important, the universal principles. That is the science behind the spinal surgery. So in this sense, the treatment of the myelopathy depends on the compression vector, deformity, number of levels, comorbidities, And essentially, the posterior approaches are indicated when the spine is stable and with overall lordosis. It's very important to take in account this. The indications for surgery in the EBM are for moderate and severe cases of myelopathy and agree with the modified Japanese Orthopedic Association score, but also for the progressive mild cases with a moderate level of evidence and a strong grade of recommendation in too many papers. DBM favors the posterior surgical approach in patients in which the pathology is predominantly posterior, and in cases in which anterior pathologies has OPLL, carotid disease, or previous surgeries forbidden the anterior accesses. In the open techniques, we have different options to choice, including laminectomy and fusion, laminoplasty, but the laminectomy has been also ruled out because the possibilities to iatrogenic instability. But currently, too many papers are talking about in the cadaver lab in a finite element analysis, talking about how if you preserve the ligaments, capsules, and contralateral structures, this possibility of iatrogenic instability diminish a lot. So this opened the possibility to make in a minimal invasive way laminectomies and laminotomies. The four universal premises that the decision-making process is influenced a lot by accumulated knowledge, science, the training as part of the art, and the experience. So in the tubular approaches, it's mandatory to correlation the clinical diagnostics as the milestone with the imaging diagnostics and functional diagnosticos until get the picture generator, usually the anatomical responsible structures. Those are essentially the surgical target, and then to center the surgical target inside the tube. The four premises that any decision may should prioritize the patient's safety, and it's very important. In my case, the tubular microscopic assisted approach offered me a stereoscopic 4K high definition vision, two hands to be more stable during the movement with the instruments, the possibility to use the usual instruments to drill and to make hemostasis, probably angle and long instruments, but essentially same tip as the open procedures. We can find some kind of difficulties to move the instruments inside the tube by frequently visual blockade with the hands, but with this problem is lesser with the learning curve. And most important, neurosurgeons frequently are more familiar with the use of microscope. So for me, the use of tubes from 10 to 18 millimeters are more versatile, even to complete complex cases, even to complete laminoplasties or fusion by posterior approach, and the possibility to directly repair CFS leakage, for example. So the rationale of the MIS tubular approaches are to respect the midline raphe and specifically the third occipital innervation to don't cause a painful usual condition with the open procedures and to maintain the contralateral side in order to maintain the stability and lordosis, respecting the raphe, preserving the muscles and ligaments and capsules, maintaining intact the contralateral side, and maintaining more than 50% of the intact facet. And we have by the way, different kinds of procedures tried in the laboratory with good efficiency to get good results. The surgical position is very important. I usually use the Mayfield holder to avoid face and eyes injuries. And I don't recommend flex or extend because it's not necessary the neck just to prevent and notice damage of the spinal cord. The neuromonitoring is absolutely mandatory. Fine tip instruments, tubes, etc., are mandatory. Probably angled and long instruments are better and facilitate the technique. The match head dissecting tools to drill the bone are really safe. And recently, using ultrasonic scalpel. The selective approach is over the side of worst compression, usually the side of the radiculopathy, in the cases of radiculopathy. And it's important to avoid the K-wire and progressive blind dilation with the tubes in order to don't chop the neurological structures. It's very dangerous. So it's better the anatomy. A progressive microdissection following the direction of the muscular bundles is wonderful, it's beautiful, it's quite simple, including trapezius, semispinalis, splenius, and multifidus. It's very easy. I'm gonna try to show how I usually make the dissection with the bipolar using a very smaller esophagus retractus, as you see, following the bundles of different layers, as you can see, and taking advantage to make hemostasis of the small vessels in order to maintain clear the bone plane at the end of the dissection, and taking advantage of the esophagus retractors to put the tubes, insert the tubes, dug the tubes inside the bone plane. In this way, we can get a very clear plane, very easy to identify the anatomical necessary landmarks. So the surgical landmarks are very easy to identify, including the midline, the laminofacet junction, the interlaminar line, and the superior and inferior lamina. Remembering that the flavum is inserted in the middle of the superior lamina and the superior part of the inferior lamina. So the winding of the tube offers a wide surgical field of action in craniocaudal or lateral medial winding. The key at the end is sparing the tension band and the contralateral a very nice phone sure of laminectomy, multiple laminectomy. This patient with an important compression of the cervical spine used to see some technical aspects about the how to make the procedure. Once we identify the borders or the flavum, as you can see, it's very easy to resect it. So sometimes behind the flavum, we can find scars to resect and to achieve a very nice decompression, as you can see, in different ways. So in reality, it's a simple procedure when we know anatomy. This is another case completing a similar approach, just to see how easy can be. And then, sorry, this is another case, similar with the B case, laminotomies in a C4-5 severe compression, military position, again, 10 millimeters tube. We don't need more to, to complete the procedure as in the usual form. And again and again, identifying the inferior and upper insertion of the flavum to resect in a completely way, and at the end, having a very nice result in the studies, but also clinically, as you can see. This is a mini video of the postoperative decompression and a mini video of the patient with a very nice clinical result. This is another case in which I made a laminectomy, multi-level laminectomy in a patient with a C3 to C7 compression, very rigid spine, not instability, and a patient confined to wheelchairs. And again, military position is not necessary to flex or extend the patient. 18 tubes is enough to complete the procedure. You can see different situations of the compression going through the contralateral side and completing a very nice bilateral decompression, segment by segment. Usually not coagulation is necessary, so be patient, some kind of hemostatic. And you can see a very, very impressive decompression, respecting the muscles in a very rigid spine with overall lordosis and with a very nice clinical prognosis for this patient. This is another case just to see a C3-4 severe radiculopathy in a patient with, you can see narrowing, severe narrowing of the foramina, left foramina, in the CT, and also in the MRI. And at the end of the procedure, we can see how we wide absolutely the foramina with excellent results over the clinical picture in this patient, with improving of the monitoring even during the procedure. So we publish our results with Weill Cornell University with my friend Roger Hartle in the preliminary series with excellent results in the patients, almost ambulatory patients. And this is a mini video just to show how in cases of leakage, CFS leakage, is possible to repair the leakage with the stitches and sealant through the tube. It's relatively simple to complete the stitches in a watertight way, adding some kind of sealant. So the results are really good. I'm happy with the results, and I'm sure the posterior microsurgical tubular approaches are a very nice way to peel an apple in the cases of minimally invasive spine surgery. Obviously, it's mandatory to accumulate casuistics and analyze results to understand the true clinical impact of this technique. Thank you so much.
Jose Antonio, thank you so much. It's wonderful presentation. It shows a lot of surgical mastery. And now, just to convince me how endoscopy is better than tubes, I ask Luke Kim to show us his presentation. You can share your screen, please.
Yeah, I'm gonna screen. Let's see my screen. Okay. Sorry.
On the bottom, yeah, screen share. Jose Antonio,
Okay, I got it.
You got it?
I got it.
Okay.
Yeah. Thank you for having me in this great European CSS webinar today. I'm gonna talk about the endoscopic laminoforaminotomy, laminectomy in the cervical spine today. So I'm gonna start with the concept of anterior approach. Sometimes we face this serious complication as esophagus and variance operation and the multi-level related implant failure and hoarseness and junctional problem like that. The Eospine have published the Eospine consensus paper on the nomenclature. We can find the cervical related the nomenclature, posterior endoscopic cervical foraminotomy, discectomy, and in the case of myelopathy, cervical endoscopic ULBD, that is over the top decompression. I'm gonna touch these topics today. Before starting the surgery, choosing the appropriate endoscope gonna be important. For the case of radiculopathy, we can use this small scope, discoscope, but in case of cervical spinal stenosis, we have the big scope right there. So also upon the patient spinal condition, we're gonna use this maneuver or top decompression. This is the basic instrument for the procedures, and I'm gonna compare what are the difference between the microscope and endoscope. I also great fan of the microscopic tubular surgery, but most specifically, I love to use the endoscope. So I'm gonna highlight different point of view between the microscopic tubular surgery and endoscope. In the case of microscope, the surgeon's eye actually far from the surgical field, but the endoscope, surgeon's eye, so it's just inside the spinal canal, especially the over the top decompression and contralateral side. That is a strong advantage. So in case of multi-level, I love to use the slalom and the case. This is the example over the top decompression, tubular microscopic surgery and endoscopic surgery. Hopefully, I hope you guys feel the advantage of the endoscopic surgery by introducing the surgery endoscope, right? Okay. At the end of the video, yeah, you can see the end block removal of the lumen flavum here. This is contralateral control of bleeding, and how can it advance our surgeon's optics for the contralateral decompression. This kind of the perfect visualization of the contralateral side probably guarantee the safety as well. Also, the full endoscopic surgery, because the endoscope itself has the optic angle minimum 15 to 25, we can preserve the facet joint as much as possible by turning the endoscope to see the ipsilateral deeper side underneath the facet joint. That is the truly important, the surgical point of view of the endoscopic surgery compared to the microscopic surgery, like that. This is case example. I'm gonna introduce the challenging case to highlight the role of endoscope. Actually, this patient had the multiple medical comorbidity and open heart surgery, have taken the medication warfarin continuously, and he also had the bamboo spine because of ankylosing spondylitis. every time he got the surgery, total knee and the total he surgeon have difficult to control the bleeding because of the risk factor. Anyway, the patient had the problem of the C6 radiculopathy pain, and I already performed the tubular microscopic decompression 2016 June at the 4, 5, and 5 stage right side. But this side, the patient complained a new onset symptom left side along the C6 dermatome. You can see there is no obvious instability over the spine, cervical spine. You can see the bamboo spine from the C1 to 3, right? That's why the patient have the problem, the foramen to the left side. This is my target, right? So patient have the two problem. One is the asymptomatic foraminal stenosis is 4, 5 left side. The symptomatic level is 4, 5, 6 left side. So we have the sort of the surgical option, and because the patient have the ankylosing spondylitis, bamboo spine, the standard gold standard surgical option is anterior posterior circumferential fusion. But considering the serious medical comorbidity, uh, open heart surgery and the high risk of the instrument failure, we need to I need to do the MIS solution, right? So what's your plan for this patient? So I did the endoscopic laminoforaminotomy. Because of the thick spinous process, I also love the tube, but in this specific condition, this spinous process may hinder the ideal location of the tube surgery. So I I wanted to use the endoscope surgery in this patient. This is post-op CT scan. You can see the excellent decompression. Actually, because this patient experienced two kind of surgery, very unique situation. So the day after surgery, I asked the patient, upon your the experience having the microscopic tube surgery and endoscopic tube surgery and both different level, different side, which gonna be better for you? So patient answer me, I favor the endoscopic foraminotomy. So we can say that winner is endoscope foraminotomy in this case. What about the follow-up MRI and a little bit long-term follow-up regarding operations? This is 24 years old male patient. I operated the cervical posterior foraminal discectomy at the 3-4 level 2015. You can see the 1-year follow-up MRI, and there is little operation scar on muscle, right? What about the alignment change? You can see the wonderful restoration, beautiful restoration of the cervical lordosis. Most kind of the kyphotic and scoliotic change of the alignment probably it's strongly related to the pain itself. So once the pain has gone, I mean, most patient could be restored to normal position like that way. What about the huge foraminal disc herniation in this 64 years? Patient had the cheek complaint, arm pain, but patient has a little bit both hand weakness and the headache. And you can see the huge disc herniation foramen, and also he had underlying ligament flavum buckling both sides. So my first target is the disc itself, but I also wanted to decompress spinal canal as well. So CT scan, there is a slight calcification of the flavum. We have various options for that, but I did the full endoscopic decompression with discectomy right there. So he is my fellow was my fellow in from Saudi. So he was surprised. Oh my God, professor, you're gonna do the endoscope for huge disc herniation? I cannot believe. But he experience, awesome experience. This is the pre and post-op, pre-MRI. This is step-by-step approach for the full endoscopic laminotomy and discectomy procedures. Once the open up the laminar, especially the cranial side, after tilting the tube to retract the exceeding nerve and the spinal cord gently, I was able to remove the most of the ruptured disc fragment like that, simple manner. And then, yeah, we can see the excellent palpation of the spinal cord. Yes, you can see the pre and post-op immediate MRI. There is no obvious operation scar there. So if you just see the axial neck muscle, there's little change could be observed. That is a excellent experience. What about the cervical endoscope for cervical central stenosis manifestation with the myelopathy and quadriparsis? Actually, I am finalizing the one of the surgical curriculum, AO spine MIS curriculum. That is the cervical endoscopic ULBD. The first step is the ipsilateral rostral and caudal laminotomy, and define the contralateral decompression as well. Once we do the contralateral decompression, we can do the phlebectomy like that way. And final step is mobilize a neural tube and control the bleeding. This is case because patient had already underwent 2-level ACDF. Sometimes we see the remnant central and foraminal stenosis, and you can see the actual patient improvement motor and neurologic deficit improve. This is step-by-step approach for endoscopic ULBD in the cervical procedures. Ipsilateral decompression, open up the base of the spinous process and midline exposure. And so like that way, we decompress. The manner actually the same with the microscope ULBD procedures. Different one is just different endoscopic armamentarium and the narrow and long instruments compared to the microscope surgery. Release the flabum from the cranial and caudal side, then we can remove the complete decompression like that. Palpate the pedicle as well. Right, that is the axial portion. There is a contralateral decompression as well. Yeah, that is a pre and post-op MRI comparison. You can see the nice decompression from the central and foraminal decompression. This is my take-home message. Full endoscopic cervical spine on the spine surgery in the cervical spine. We have sort of the option discectomy, foraminotomy, laminoforaminotomy, and eventually we can do the cervical endoscopic over-the-top decompression like the lumbar spine or microscopic cervical ULBD microscope surgery. Actually, I believe the most indication of MIS microscope spine surgery are rapidly replaced by the full endoscopic spine surgery in cervical radiculopathy and myelopathy as well. Thank you very much.
Thank you, Kim. It was wonderful, wonderful lecture. So I can't say who's the winner. I'll leave it to the participants. But I have here some questions addressing Dr. Hassan Hamed. He's asking about instability. He says, I see that they may get some segmental instability with lots of lamina and facet joint being removed. So this is a question for both of you. And also another one from Jean-Pierre. He was asking initially about any tricks dealing with foraminal venous bleeding.
Following the universal principles, these kind of procedures are reserved just for selected patients in which there is not any evidence of instability. And as part of the procedure, we have the responsibility to respect the contralateral side, the more than 50% of the facet joint, including the capsule and the midline raphe. And when those issues is very, very lower the possibility to get instability.
I also believe most of the degenerative cervical spinal disease could be treated by through the posteriorly. Hopefully, personally, I treat the patient in the case of 1 level and 2 level. I try to treat the compression, try to do the surgery by endoscopically. In the case of more than 3 level, I love to the laminoplasty classic manner and the MIS multi-level decompression under the microscope surgery. Regarding the instability, I don't personally also I have the recurrent following the posterior cervical endoscopy. Eventually patient underwent multi-level instrumentation surgery, but in more than 90% patients have been very well. Actually, the recurrence of instability following the decompression alone, regardless the endoscope microscope surgery, is quite lower than the lumbar spine, right? So I think we can adopt the endoscope surgery more and more in the cervical spine.
Yes. I would like to mention that the comparison among endoscopic and microsurgical techniques is related with a minimal difference. But when you use tubular approaches, you can make a very more complex procedures compared with endoscopic procedures. For example, you cannot make a laminoplasty by endoscopic because it's gonna be very difficult.
Yeah,
You
true.
cannot
Yeah,
make
you are right.
cannot make a rigid fixation, and I can make it. You cannot resect a tumor, medular tumor. You cannot. I know. My idea is that endoscopic is excellent, but it's very limited to the compress, just to resect small pieces of bone or ligaments, and not to complete complex cases. Is my opinion.
Yeah, it's true. So I actually favor in this symposium webinar, I favor endoscope, but frankly speaking, I am conducting the randomized control trial between the full endoscopic cervical surgery versus microscopic tubular surgery. Up to based on my clinical data is not published yet, but hopefully it's gonna be published next year. I cannot find any difference between the two procedures. Contrary to cervical lumbar spine, I believe the lumbar spine endoscope has the little bit the better point of view clinical result compared to microscope surgery. But in the cervical spine, I cannot find the definite advantage of endoscope over the microscope surgery.
Okay. On the other hand, recently Kyle Wandrowski, Tony John, and the group published a very nice paper talking about that at least 20% of the patients with endoscopy in the post-op have dysesthesias or paresthesias, and with the microscopic is usually you don't have those kind of consequences, probably because the use of laser or thermocoagulation to make hemostasis, the radicularis is more frequent. What do you think about?
Yeah, it's I know that paper, but you see the Dr. Gonchoi today as well. But the post-op dysphagia following the lumbar discectomy, transform discectomy, the Tony Young and Lewandowski is the transformal endoscopic guy. They are good surgeon, but there is a truly geographical difference regarding the depends on surgeon skill and depends on the policy outside in and inside out technique. So I think I know the Dr. Goncho is one the best endoscopic surgeon. He was also my mentor as well. I cannot find not any. I just see the dysphagia among his surgery is less than 1%. It's true, but so I can say that your comment right now is there's a little bit I'm sorry for that, a little bit geographical and this distribution discrepancy among the surgeon.
You touch the key of the spine surgery, the skills. You have the skills to make endoscopy or microscopic or open. The idea is to get the best results.
Exactly.
In medium, the safety of the patient, because
Look,
it's very important.
Exactly. Look, since you do both tubular and endoscopic,
Yeah,
because
sure. That's
yeah, and
why
because
I do the randomized control
time,
trial.
right?
Yeah.
Time is money. Which one is in your hands the quickest operation?
As you
The
quick
tubular
time, yeah, tube is quick surgery. Yeah. So even though the best endoscopic surgeon in Korea, we cannot overcome this time of the microsurgery with the endoscope. Regarding time, operation time, the tube surgery, microsurgery is the best, right? There's no argument for that.
Dr. Choi, do you want to comment something on these posterior approaches?
I usually I taught my fellow, you have to know, you have to get a skill for anterior and posterior and microscope, endoscope, all the procedure, and then you can choose the best option for the patient. Every patient has a different uh, anatomy and different disc herniation. So if you can do endoscopically, if you can do microscopically, if you can treat the patient, and definitely endoscopically treatment is safe and minimally invasive. We can save the facet joint, we can save the muscle and ligament. So actually I do many of, still I'm doing the open surgery, the fusion surgery and laminectomy surgery as well. But always think first endoscopically, minimally invasive. So I cannot say which one is best, but there is definitely some procedure is best for the patient. Is that my comment?
And that brings
thank you.
a question, if you allow me, a question for Dr. Kim. I'm very interested in that RCT you're performing, but what interests me, what is your primary outcome measure? What do you think is the most important difference to come out between one and the other method?
Yeah, thank you for asking me my study ongoing. So I primary endpoint, I remember that is the ODI score 1 year. And I haven't measured the radiologic data as well, not yet, but the clinical outcomes are actually the same. I found the 2 patients had the recurrent disc herniation following the endoscopy surgery. So I operated again the anteriorly fusion. I also the performing randomized control trial in lumbar spine, over the top decompression and discectomy procedure as well. It's I find a little bit better outcome in endoscope surgery in lumbar spine, but in the cervical, I'm not sure which is gonna be better. But personally, because I'm the teaching guy, so I need to teach the international fellow and my fellow, because the endoscope, regarding the endoscope, we have the huge unmet need from the patient. Patient want to get the surgery from with the endoscope. That's why one of the reason for that.
Thank you. So I think Dr. Choi really said an important message is that a surgeon has to know how to do different surgeries and then tailor to the patient, and this will be the key to success. So I'm just going to present a very brief lecture. When you consider MIS procedures, it's always nice to have the possibility to have a fusion procedure that is an MIS on this surgical decision-making process. So my lecture is on posterior interfacet fusion, MIS. Okay, I do get some teaching honorarium for Providence Medical Technology, who has this designed this implant. The open posterior laminectomy and fusion has some benefits, avoids the risks of the anterior exposure. You can access multiple levels. That's the widest the compression technique of the canal, high fusion rate. But the open technique has morbidity, iatrogenic morbidity related to muscle denervation, ligament section, long operative time, increased blood loss, longer length of stay, a readmission rate that it's not neglectable, very important postoperative pain, equivocal results concerning sagittal alignment, and of course all the screw-related complications. This MIS posterior facet joint fusion technique has the pros of being a tissue sparing dissection and stripping technique, direct access to the facet joint, and shares many of the good things of the MIS technique as lead blood loss, improved operative time, shortened hospital stay, less post-op pain, reduced infection, and very fast recovery. Of course, it's an indirect visualization, and you rely on radiation exposure, and this could be bad for the team and for the patient. As Jose Antonio said before, this study shows that with this technique, there is very minimal muscle injury leading to reduced muscle atrophy, and of course, from that you collect less pain and less long-term kyphosis. The length of stay, as you see here in this study, it's not related to the number of treated levels, and it's roughly 1 day of in hospital stay. This is the setup in the OR. You do your external marking very carefully, prone position, you need an X-ray. The technique, it's very easy to learn. You should go from medial to lateral. This will guide you away from the canal. And the vertebral artery is protected by the pedicle. And fortunately, in the cervical spine, the nerve root exits in the bottom of the foramen. So if you keep behind the posterior wall of the vertebral body, you don't hit the vertebral artery. What about the mechanical stability? Here you compare these posterior cages with lateral mass screws, and bilateral cages afford the comparable segmental stability. If you supplement single or multi-level ACDF with the posterior cervical cages, you have an increase in stability, as you see here. Clinical outcomes, there is an improvement of very, very comparable to traditional techniques. What about fusion rates? At 2 years, you see almost 100% fusion rate, and the translation motion less than 2 millimeters in 100% of patients. And why you get good fusion rate? Because the surface area of the facets is comparable to the interbody surface area for fusion when you do an ACDF. Also, you have a shorter distance for bridging bone between the facet than you have in in an anterior approach, intersomatic approach, and very good bone quality here done here on the facet joint. There is no evidence of significant loss of lordosis. And why is this? Because the device is parallel shaped. It's a parallel shaped device and does a distraction. And as you see here in this study published in 2015 in Journal of Neurosurgery Spine, there is not much change on the sagittal alignment. And why is that? Because the facets are closely behind to the center of rotation. So the applied moment arm from cervical facet destruction is much less than the ones we are facing when we insert an interspinous process device in lumbar spine. Complications, as you see here, are very low rate of complications. In this study, no reoperation, no device-related complications. Adjacent segment disease compared with other techniques, anterior or posterior, virtually very small with no cases of reoperation. When can you use this technique? Whenever you want to avoid to reopen an anterior approach in symptomatic non-union or adjacent level disease, when you have a failed total disc replacement, or if you want to do a 360 fusion, or you do a laminectomy, and at that time you can insert the cages, or in the case you have an isolated foraminal stenosis, you can take advantage of doing some indirect foraminal decompression. Good results in the case of symptomatic pseudoarthrosis, very small length of hospital stay compared with anterior or posterior techniques. Very good positive clinical outcomes and 100% fusion confirmed by CT or X-ray. This is a case here of a pseudoarthrosis, and this was nicely solved with this small operation and quick operation. Again, another case here that was nicely done. This is a case of a patient that I had with a failed arthroplasty. It's a regular case, but patient improved with arthroplasty, good resolution of arm pain and neuro recovery. But 9 months post-operatively, she had a terrible pain and important hypermobility of the level of the disc prosthesis. C5-6 facet block produced relief of pain and inserted this to avoid to reopen it again and take out the disc prosthesis and obtain this very nice fusion. And 18 months, I saw her recently, she's asymptomatic, and even the foraminal height, there was an increase. I think it's a really good indication when you have isolated foraminal stenosis. We heard today about the posterior foraminotomy, and especially in the old series, the reoperation rate is important. It's almost 10%, but it's follow-up dependent. The more you follow the patients, the more reops you get, and this can reach 10 years, almost 1/4 of the patients. It has its own limitations. The degree of decompression is limited by the amount of bone that can be safely removed, and this should be between 35 and 50%. If you do a bilateral decompression, you have a higher risk of instability. You don't have any fusion when you do a foraminotomy. It doesn't abort motion, which sometimes is part of the problem. And if you have a persistent facet joint pain, axial neck pain, it's a contraindication for posterior foraminotomy. This is a case of isolated foraminal stenosis, and this is what you get by a simple technique. The concept is to increase the foraminal height. Here another case, multi-level, and this is what I achieved with a very small incision. This could be done very successfully. Very good results, as has been shown in this paper by McCormack. So in conclusion, it's a technique with low morbidity. It's live tissue sparing technique, avoiding many of the approach related complications of open anterior or posterior approach. Provides indirect and bilateral, very important foraminal decompression. Can stabilize at the same time you do the decompression. And high rates of fusion that are important to control the long-term outcomes of the the radiculopathy. It's cost-effective, disposable, quick operation, day surgery, less or virtually none postoperative pain, a very short learning curve. Of course, it has its own limitations, does not address cord compression, although it can expand the canal dimensions by reducing the buckling of the PLL and ligamental flavum. Major instability is contraindicated. It does not cause kyphosis, but does not help also to reduce it. Thank you so much, and invite you to our annual meeting, CSRS Europe in Paris, and Philippe Ancel and Carmen are the hosts of this event.
Thanks a lot, Oscar. Very, very interesting technique. And I think we will hear a lot of more about that in the coming years. I just have one small question. That is, do you reach immediate fusion, or do the patients need to wear a collar afterwards?
Yes, I put them on a collar, Cameron. It's the primary stability is good. The one, I mean, once you insert the cage, you cannot really take it out. You need a lot of, so primary stability is good, but I usually use a collar and I have to say, this case of the arthroplasty that I showed you, fusion took a while to be seen. I remember to do an X-ray by 2 months, 3 months, and there was no very scarce fusion there. The patient improved because the facet was blocked, but it took a while to see the fusion. And I see Katarina from Sweden is asking here a question. I just use a soft collar, don't need a very rich immobilization.
Okay, thank you. Is there anybody else from the faculty who has a question?
So it's wonderful surgery. It's a minimal invasive. If you have one patient is only one side radiculopathy because of foraminal stenosis, can you do just insert of KG is far side for relieve the patient one side? Is it
Dr. Choi? Yes, it's really a good question. It crossed my mind when I started to use the implant. But although the implant height is not that big, I think it's not recommended to do just unilateral. You might risk some sort of little scoliosis or whatever. So I think it's always advisable to do both sides in order to really be able to block the movement at the level.
Oscar, another question came in via the chat. Dr. Cunha asked what kind of material the cage is made.
This is made in titanium.
Okay, like most of things. Well, I noticed that you were speeding up a little bit to stay in time. So I suggest you continue and take over now.
Okay. So now I call Jean-Pierre. Let me close this. I'm sorry. So most of I'm sorry, Jean-Pierre. So most of the MIS techniques they rely also in the development of these navigation systems, either intraoperative CT or neuronavigation. And this made an important, the concept of total navigation has changed the workflow and minimized radiation exposure in cervical spine surgery, where landmarks are really small compared to lumbar spine. So reliable, accurate navigation is really useful. So this is very important lecture by Jean-Pierre Mauvasse. You will focus on these procedures and hopefully some outcome data on each. Jean-Pierre is a neurosurgeon and president of Goodman Campbell Brain and Spine Center and clinical assistant professor of neurosurgery at Indiana University. He's the president of Society for Minimal Invasive Spine Surgery and is acknowledged as a frontline expert in navigation and robotics. Please, Jean-Pierre, it's an honor to have you here.
Thank you very much. Can you hear me okay?
Yes.
Great. So I'll start with my disclosures, and I want to thank everyone for inviting me to speak today. I'm honored to be a part of this. So first, I want to talk about navigation and what the uses are. A lot of times people believe that navigation is purely for placing instrumentation, and I think that's how navigation starts, but we've moved on to using it for other things to make it more valuable in our day-to-day practice. In the cervical spine specifically, you can use navigation for placing occipital keel screws in an occipital cervical fusion. It's very helpful in C1, C2, and T1 and T2 screws. But we can also use it to assess decompression if we're doing a cervical corpectomy and we want to see how close we are to the vertebral arteries to make sure we've gotten wide enough. And then we can use it in assessing tumor resection, particularly bony type tumors in the procedure. What are the drawbacks of navigation in the cervical spine? One of the biggest ones is the mobility of the spine. So because a patient has mobility, you have to be very careful with the amount of force you apply to the spine, because then that can affect your accuracy. So we tend to leave our retractors in when we are acquiring a 3D acquisition of the patient's spine, because if you watch as you're expanding a cervical retractor, you can see the spine move. So we do not want to take the retractor in and out, and the amount of metal artifact from the retractors is there, but it still doesn't obscure your view from utilizing the image. Also need to make sure that the clamp that you use is not in your way. Typically, we like to put the clamp on C2 or perhaps the thoracic, depending on what we're doing. But if I was going to place C1 screws, then the clamp being on C2 could be in the way. Also, if I'm going to be decompressing, I have to make sure that the clamp is not in the way. So a lot of times we'll use the Mayfield pins with the cranial frame attached to the Mayfield pin site so that the frame is out of the way. And then again, there can be line of sight issues with seeing instrumentation from C1 and T1 and T2. If you're doing a C2 to T2 fusion, having the angles so that the camera can see both the instruments while you're placing screws at C2 and T2 is very different angles. So it's important to learn how to position and utilize the navigation in that way. So where do you place the frame? It depends, as we've said. I've moved more and more towards the cranial frame attached to the Mayfield pin because it keeps it completely out of the way. But if I'm doing a subaxial cervical fusion, then placing the frame on C2 with the camera, the head of the bed works well. And I can also utilize this for T1 and T2. So this is just an example of patient positioning. And you can see in this case, this patient has an upper thoracic kyphosis, which makes the angles a little bit harder. You can see how we've elevated the patient's head of the bed. And then we have chest pads and hip and thigh pads to make it more comfortable for the patient's anatomy. There are various different ways to do this. I'm just giving you an example of how we do it here. And this is a more close-up version there. For fusions, the neck needs to be in anatomic alignment because you don't want to fuse somebody in kyphosis. For decompressions, I know that someone earlier mentioned that they like to keep them neutral, and that is fine. I find that flexing the neck a little bit makes it easier to get into the foraminal space if I'm doing a foraminotomy. This has been shown by others, so I'm just going to keep going through this, but this just shows the anatomy and the tubular position, but it's been shown well by others here already, so we'll keep going. This is an example of navigation, and so what you can see is if you were doing a posterior cervical decompression, again, we use the reference arc attached to the Mayfield pins. This is your probe going down exactly on the facet joint. Uses of this, if you had somebody who's morbidly obese and you're having trouble visualizing the lower cervical spine, navigation would be a wonderful tool for a simple posterior decompression. You can utilize that tool to actually localize the level. And unfortunately in America have a morbid obesity problem. So this actually becomes more and more useful for us when we can't see down past C3 or C4 in positioning a patient. What are other ways to do this for various uses? Again, as we figure things out, this is doing an anterior cervical decompression. So if you look at the bottom, you can see there's the vertebral foramen on one side, there's the vertebral foramen on the other. And we've basically attached a clamp to our retractors. Again, this is not going to give us the kind of accuracy we need for screw placement at C1 or C2, but it's perfectly good accuracy for assessing our decompression and how close we are getting to the vertebral arteries to make sure that we've gotten lateral enough. When I've obtained postoperative CTs in a cervical corpectomy, I've frequently been disappointed with how much room I had not decompressed in the lateral recesses, and being able to spin an image intraoperatively and see your level of decompression. And if you want to use navigation to aid it, is a great tool to make sure you don't have those disappointing results. So I'm going to go through a couple of cases. This was a person who had a C1 fracture, a bilateral ring fracture that was treated appropriately with the collar. But as we all know, sometimes these don't heal properly. He came back to our clinic and had 12 millimeters of subluxation on flexion extension x-rays and was developing neurological symptoms as a result of this gross instability. So you can see the fracture here going through the foramen. Choroidal alignment was fine, but you can see the fracture here. And then you can see the fracture again in this view. Treated with the collar, was not an unreasonable treatment choice, but unfortunately came back with a significant instability. Again, no significant stenosis requiring decompression, just stabilization. So this is a use of navigation for us. So again, you can see I've placed the frame here at T2. This is early on in doing these cases. Now I would use the cranial frame because this can be in the way for the C1 screws and navigation instruments. This shows us our instrument. The yellow is our target line, so we can measure the length of the screws. And this is showing my angle, so I can measure exactly how long I want the screw to be. What's been so wonderful about navigation is I can place screws within a millimeter of the foramen transversarum quite safely, knowing where I am. And this is showing the placement of the screw at the C1 lateral mass, and again, measuring. What's also nice about this is I would, intraoperatively, I would extend that line just in front of the ventral cortex of that bone, so I could get bicortical purchase in this, so that I have a nice stable construct. So I will typically get bicortical purchase and can do it in a very controlled fashion where I will have 1 or 2 threads of the screw through the anterior cortex for that purchase, but not anything further than that. And then this is also very good for looking at the vertebral artery anatomy and your alignment. You can see a little bit of the subluxing position, but we were able to get this patient fairly aligned. We have taps that are navigated that we can use for this. Again, determining the length of the screws. And now we have nice CAD models of the screw that can show the screw as it is going in your trajectories, both for C1 and for C2, with a nice final construct result. This is a more interesting case. This is a 12-year-old male with Down syndrome who had worsening neck pain and was seen and found to have some developing neurological symptoms, which again, it was hard for the boy to communicate, a very active boy, but his mom noticed he was having several problems. And so we brought him in, examined him, found him to have signs of developing myelopathy, fairly significant myelopathic symptoms. And then you can see here with the gross instability and malalignment at the occipitocervical junction, with his odontoid in the middle of his foramen magnum, and actually probably even a little bit posterior. So very little room for this child's spinal cord. So you can see the different views, and unfortunately you can see that the C2 lateral masses are quite small and very difficult to cannulate. And this is the MRI showing the severe stenosis with the signal changes in the cord, but also the difficult alignment of the odontoid and trying to perform any surgical procedure here. So what are the options in this case? Transoral decompression, very hard in a 4-year-old child. Also in a Down syndrome person who has an enlarged tongue would be almost an impossible operation to do. Posterior procedure, definitely going to need posterior surgery incorporated into this operation. And then the question is a transnasal endoscopic odontoidectomy, transmandibular approaches, or Le Fort osteotomies. So the transoral, we talked about the disadvantages. We looked at the odontoidectomy based on these papers out of Johns Hopkins. And we actually looked at this before doing the case and looked at their images and thought this looks like a great option for this patient using this minimally invasive approach to get this high in this child and then decompress. So this is where the confluence of minimally invasive and navigation come and are additive to each other, creating a better procedure for the patient. Also, going the transcervical approach allows us as spine surgeons a much more comfortable approach without needing an exposure surgeon to find for this. So we place this child in traction to try and reduce some of the basilar invagination and a halo to hold him in that during the operation. He was extremely unstable. In fact, when we positioned him the first time, he lost some of his motor function, so we had to reposition in order to achieve this. And you can see how we had to lock him in position in order to hold him in a stable position to do this operation. And you can see here's our retractor, Doc. So this is the minimally invasive tubular retractor that's angled to fit along here. You can see the ring of C1 here, and here's the odontoid. Obviously, the angle is not optimal for drilling all of this out, but the goal is to just get the tip of the odontoid and provide some room for the cord. We started with the endoscopic camera, but actually found that it was actually more difficult to utilize the endoscope in the limited amount of working room in this particular case. So we then removed the arch of C1 and cleaned off the odontoid and then resected the top of the odontoid. And this is where navigation really helped us. You can see us utilizing the navigation probe to identify the odontoid. This was before we had navigable drills, so we did not have the benefit of a navigable drill in order to do this. But we would stick the probe in and see how close we were to the patient's brain stem and how much we could drill properly. Once the pressure had been removed, we turned the patient over to stabilize them posteriorly. Again, using navigation for the placement of this instrumentation. And what you can see is the end result is we were able to get a very nice decompression with removal of the odontoid using this combination of minimally invasive and navigation in order to do that. And you can see how significant the decompression was in the cervical spine from where we started. And this shows that axial view where you can see the spinal cord has a thin rim of CSF all the way around it compared to where we were before. Also, what was really nice for this child is you could see all the edema he had in his cord has gone away, and he returned to a very nice active lifestyle. So in summary, I want people to start thinking a little bit more outside the box, that navigation is not just a tool for placing lumbar pedicle screws. It is something that can be used to watch your decompressions to assess where the vertebral artery is, especially due to its variable course in the cervical spine, particularly at the C1 and C2 levels. It's great for localization if you run into issues with patients where you can't get an adequate image on with a C-arm. It's very helpful for us in some of the tumor surgeries that we do, particularly when we can see the anatomy, we can see the vertebral artery in relation to the cervical tumors, and can be very helpful in that fashion. Robotics, I will not claim to be an expert in robotics. We do have a robot at our hospital, and I have used it several times. I will tell you, at the robot that we've used in its current iteration, I would say is a step backwards in function compared to what we have with navigation today. Navigation I can use for more uses compared to what we can do with the robot. However, as we all know, the robots are in their infancy of development, and I expect they will continue to progress and become more useful in a wide array of options. Right now, robotics is more focused on screw placement, at least in spine surgery, but I expect these uses to expand over time. And I would also expect there's going to be a time where the robotics surpass the navigation, but right now for us, it has not got to that point. The companies have just started to combine navigation with the robots, which has been very helpful. And I expect those uses to continue. I talked to one of the companies about their, right now, there's very few uses in the cervical spine for robotics, and they're not recommending it. At least most of the companies are not who have these robots, but they are working on this actively, and they are looking to the future to develop uses for cervical surgery. And I believe once you have the robotic advantage in cervical surgery, things like Oscar showing placement of these percutaneous facet grafts may become more comfortable for some surgeons who don't have that level of skill and have concerns about performing a lot of the techniques that we're discussing. Thank you.
Thank you, Jean-Pierre. Wonderful lecture. What do you think is the role of augmented reality? I totally agree with you. Robotics is a step back compared to what we have with navigation, but the augmented reality stuff that we see already for lumbar spine.
Yeah, I think it's really interesting technology. I've actually played with it in the lab a little bit and talked to several surgeons here in the United States who are actively using it. What's really interesting to me is the people that have gotten enamored with augmented reality, they almost skipped the navigation part. They went from C-arm utilization to the augmented reality, and they almost skipped all of the navigation part of it. I certainly think that I think it's really interesting technology. Again, it's in its infancy. One of the companies asked me to assess their augmented reality headsets, and I said, it looks like a prototype. It's heavy. It would tire your neck. Your neck's could be flexed with this additional weight on it. But I expect when they get those augmented reality down to like a Google Glass, where it's no heavier than a pair of eyeglasses, I think that its use may explode and take off, because you can overlay the navigation with the augmented reality. So I expect that's something that we will all see expand over the next decade.
Carmen, any questions?
No questions. I really enjoyed this presentation, and I will look into augmented reality one day. And well, thanks a lot for your presentation.
Thank you very much.
Any other questions for the panel?
Yes, one question. One concern about those technologies, navigation and robotics, is the cost, especially in mid and low income countries. It's very difficult. So my question for the speaker is the difference among the traditional techniques versus using navigation and robotic is so big to justify the high cost?
Yes,
I understand the safety. I talk about the safety, but I would like to know.
Yeah, no, Jose, that's a wonderful question. And I think it's something that needs to be taken into consideration. They are extremely expensive and cost prohibitive for lower income countries, but there are disruptive companies coming out. There is a company right now that Kevin Foley's involved in called Fusion Robotics, and they're going to provide a robot that is probably 1/10 to 1/4 the cost of the existing robots. And it actually just received FDA approval in our country. So I think once that robot comes out, you're going to see the costs, because there'll be a competitive robot out there at a more affordable cost. You're going to see that landscape change. There are studies also out there looking at the cost of the robot and how does it of the navigation and the robots and how they justify themselves. And I can tell you from a navigation standpoint, I have been using navigation for 17 years, and I have only ever had to take one patient back to the operating room to replace a screw. And that was back in the first year, 17 years ago, when I placed too long a screw in the sacrum and it was abutting the iliac artery and vein. And that was my fault. It wasn't the navigation's fault. Since then, I'm able to see when my screw is misplaced. And there are going to be misplaced screws even with navigation. When you're leaning on the fascia, you're getting a false impression of where your screw is. There's lots of trips and ticks that are important to making sure your navigation is accurate. But what you can get is a post-operative spin in the operating room to see that something's not where it should be, and you can correct it at the same site. So if you look at the revision rate for misplaced instrumentation at our hospital amongst navigation users, it's extremely low. And that's a cost savings to the system by that patient not having to go back to the operating room compared to the historical number of cases you can see of people who have to be taken back. So I don't think it justifies the costs as they exist today. I think the costs for this equipment are bloated and need to come down. And I think as we believe that competition is going to bring down those costs. And now that a robot is coming out and will shortly be available on the market for probably 20% of the cost of the existing robots, you're going to see things change.
Perfect. By the way, I'm using daily navigation. And the other question is very, very interesting. From the ethical point of view, who is the responsible with the robot commit an error? Who is going to be the responsible?
Well, you know, that's a great question. That's one of the things that really bothered me about the robot was with navigation, I have to judge the accuracy. I have to know where the instrumentation is. I need to know that it's accurate. When they had robots to start with where there was no navigation, I was stunned that surgeons in America were so willing to trust it, to go out and to trust it. And I know of cases where the screws were misplaced with these robots, again, due to scything, due to tension and the angles that were on the tissues. But we as navigation users understand those forces and how we have to account for them. So the fact that surgeons were so willing to adopt a robot when they couldn't see anything and blindly trust it, I couldn't understand it. Now that the robot's moved into being used in combination with navigation, it makes more sense to me.
Thank you, John. Thank you.
Thank you,
Oscar.
So I think it's time to conclude. We have been, time runs really quickly. We are now approaching 2 hours. So we heard from the experts, and I think they offered a brilliant review on how cervical spine surgeons have become more, increasingly less invasive with good clinical results. The future of MIS application in cervical spine will continue to evolve over the coming years, as we guess from some of the presentations here, with wider indications and new technologies. So to conclude, I would like to thank Ana Luisa for her great support. She did a huge job hosting this webinar. And I'm really grateful to our entire faculty. They were luminous in the way they address a very cutting edge topic and generating very clear own message. Especially, I'm thinking about Dr. Choi and Luke. They are almost reaching midnight in Korea, so it was a big compliment for them. Big thank you. And thank you also to all the participants we had across the globe, from Japan, China to South America, North America. And you are the reason why you organize these meetings. Stay safe. Hope to see you next time. Carmen, do you want to address a final word, please?
Thank you, Oscar. You thanked everybody, but we also like to thank you because you were responsible for inviting the guests and the faculty, and you made this all possible. And I really liked it very much. So thank you for giving me the opportunity to moderate together with you.
Thank you, guys. Well, it was a really pleasure. Thank you.
Thank you so much.
See you next time.
Stay in the loop.
Thank you.
Bye-bye.
Bye-bye.
Thank you so much. So long, everybody.
See you in minutes. Bye-bye.